Thank you, ma'am. Now I'm going to discuss about the role of serology in diagnosis and control of COVID-19. As we know that SARS-CoV-2 is a novel coronavirus with tremendous human-to-human transmission. And since there is no previous exposure to it, so everyone is susceptible for the infection. Till date, we do not have any effective preventive or therapeutic drug. So because of this, there is high chance of because of this the pandemic is increasing. And for diagnosis of this SARS-CoV-2, as ma'am had already told, the RT-PCR is the gold standard test, and then we can have another test, that is rapid antigen test, which is rapid, but the biggest drawback of the test is that it is very less sensitive. And then we can perform the antibodies testing. But at this point of time, I want to make it very clear that this antibody testing is generally used for routine surveillance, zero surveillance, and screening of the healthcare persons only. So the prescription for containment is test, trace, and treat. That is to isolate the patient is the mantra of the control of the disease. But these all efforts are not working efficiently in halting the spread of the infection, because there are many asymptomatic cases which are spreading the infection. Now this is the basic structure of the corona SARS-CoV-2, and these are the basic these are the basic proteins like spike proteins, nucleocapsid proteins, envelope proteins, and the membrane proteins against which the antibodies are generally formed. Now, in brief, I can in this slide can see the how the SARS-CoV-2 infections infect the human cells. The basic structure of SARS-CoV-2 have a spike protein. So this spike protein has basically S1 and S2 component, and through S1 component, the virus generally binds to the ACE2 receptors on the human cells, and through S2 receptor, the virus enters in the human receptor cells. Now the course of the infection can be divided into three major parts. That is the incubatory phase, is the phase when the virus come in contact to the human, and there is multiplication of the virus in the human body. Then there is a infectious phase, and this is the most dynamic phase in which the person shows the symptoms like fever, sore throat, stuffy nose, and sneezing and coughing. And this is the time when there is high viremia and there is high load of virus setting in the respiratory secretions. And this is the time when we can diagnose the virus with the help of certain various molecular tests which madam has discussed. And in the middle of the days of onset of the symptoms, at around 5 to 7 days, the first antibody to appear is the IgA, and this is the antibody which has high significant value in the disease outcome and severity of the infection. Then this IgA is followed by the appearance of the IgM antibody, which is further followed by the appearance of IgG antibody. So the total seroconvergence for total antibodies around 11 days post onset of the symptoms, which is followed by the IgM, which is around 12 days, and followed by IgG, which is the seroconversion for IgG is around 14 days after the onset of the symptom. Now in this slide, you can appreciate that the maximum virus shedding is in the early symptomatic phase, and it may be before the appearance of symptom, that is called as the pre-symptomatic phase. So the virus shedding is maximum 2 to 3 days before the appearance of the symptoms to 5 to 6 days after the appearance of symptom, and this is the best time where we can diagnose the disease with the help of molecular test as well as the antigen test. Then after 5 to 6 days of appearance of the symptoms, the antibody starts to appear, and then comes the recovery phase, in which generally the antibodies are formed after 2 weeks of post onset of the symptom. Now this is a chart which shows the rapid antigen testing test given by ICMR, If the rapid anti-test is performed, if it is positive, then we have to declare the patient as positive irrespective of the status of the patient. And if the rapid antigen test is negative, then we have to look for symptomatic fever, cough, sore throat. If these symptoms are present, then definitely we have to send the sample for retesting by RT-PCR. And if the patient is asymptomatic, then if individual turns symptomatic, then repeat a test by rapid antigen or test or RT-PCR has to be done. Now this is a chart which beautifully explains how the sensitivity of RT-PCR decreases with onset of the symptom, and the maximum sensitivity of RT-PCR is at around 3 to 4 days after the onset of the symptom. Then it gradually falls and it becomes almost undetectable by 25 to 26 days. And gradually we can see that the testing, the sensitivity of this serological test gradually increases, and it reaches up to maximum by third week of third week post symptomatology. Now these are the important attributes of the available serological test. Here we can see that the antibody, that is IgG, which is against the antigen, that is S1, and RBD antigen, that RBD is basically the receptor binding antigen. If the antibodies are present against these antigens, then this means that these are basically the protective antibodies or the neutralizing antibodies. And if the antibodies, total antibodies or the antibody against IgG, which are formed against nucleocapsid antigen or S1 antigen, if these antibodies are present, then we can predict that the person is exposed to the infection. And here we can, in this table, we can compare the various tests like molecular tests like RT-PCR, CVNet, and which has been discussed by ma'am, and the rapid antigen test which we can do for diagnosis of rapid coronavirus SARS-CoV-2. And this, the main target is the protein fragment of SARS-CoV-2 virus. And this is the advantage of this test is that this is a rapid test and it requires only around 30 minutes, and the reporting time is around 60 minutes. But the biggest drawback of the test is that it is sensitive only up to 40%. And other antibodies tests which can be done is the total antibody test. These antibody tests are against the nucleoproteins, and that can be performed with blood, serum, or the plasma. And the time required is only 60 minutes, and reporting time is around 4 hours. And the sensitivity and specificity is more than 95%. And the another test which we can do is against the antigen S1, S2 spike, that are basically for the protective antibodies or the neutralizing antibodies. And the turnaround time for this is 60 minutes, and the report can be validated within 4 hours. And the sensitivity and specificity of the test is more than 90%. So on 23rd June 2020, ICMR has included this IgG antibody testing only for screening of the healthcare workers, and for this this test can be done by the use of ELISA and CLIA, and this test can be performed by government and private hospitals, officers, and public sector units. And this test can be performed on immunocompromised patients, individuals in containment zones, healthcare workers, etc. Now this is an algorithm which shows that how the antibody test can be used for systematic screening of the healthcare personnel. If we can use the serological test for screening of the healthcare personnel, and if there are new employees, then we can, along with this serological test, we can use RT-PCR for screening. If it turn out to be serological test turn out to be positive, then we have to differentiate between active cases from the past infection with the help of 2 RT-PCRs. And if the test again come out to be positive with RT-PCR, then we have to go for case isolation, contact tracing, and clinical audit. And if it RT-PCR turn out to be negative, this indicates it's a past infection. So should we go for antibody testing for surgery? If we perform the antibody test along with the PCR test, and if both comes out to be antibody test come out to be positive and RT-PCR comes out to be negative, then we can carry out the surgery without, and at time of discharge there is no need to go for further testing. But if PCR and antibody are negative, we can carry out the surgery, but we have to go for PCR testing every 6 to 7 days, and we have to do the exit PCR test at the time of discharge. But if RT-PCR is positive and antibody test is negative, then we have to postpone the surgery. Now, this is an important question that should we use plasma therapy for the patient? Yes, we can use the plasma therapy for the patient, but if the donor, we have to check first for the neutralizing antibodies in the donor. If the neutralizing antibodies are present in the donor, we can use this as a this plasma for conventional plasma therapy in the patient. So when a person can go to the back to the work, if the person has well antibodies formed against the SARS-CoV-2, and if there are neutralizing antibodies present, then of course patient can go, the person can go back to the work. In the last, I would like to say that SARS-CoV-2 in COVID-19 infection is a moving target, and the current presentation is based on available information. Recommendations may change depending upon the availability of better scientific data.